Thank you. I'm not contending for the competition, so please don't mark me. Uh, I want to present these two side effects of ocular allergy and pattern electroretinographic changes with the application of 0.01% atropine eye drops. I have no financial interest in anything mentioned in this PowerPoint presentation. As we know, low-dose atropine eye drops have become first-line treatment for progressive myopia in children between 6 and 12 years of age, usually used for 2 years with an effectiveness of around 50% slowdown in progression of myopia. However, not much is known about the ocular allergy with 0.01% atropine eye drops. I've been using it since 2013 after an interaction with Audrey Chia in Indonesia. She says she had in ATOM 2 study around 1% or less than 1% incidence of atropine 0.01% allergy, while in ATOM 1 study they had 4% as the incidence of atropine allergy. However, they have not published about its clinical features and how they have managed them. So over last five and a half years, we have prescribed 0.01% atropine eye drops and used it in around 1,000 children, of which only 4 till date have developed allergy to 0.01%. So it is fairly infrequent occurrence in patients using 0.01% atropine, and it could happen in a very young child. As you see over here, a 5-year-old child had also developed it, and even in an older child like 15-year-old child had also developed it. There is no gender preponderance. You have males, females both getting atropine allergy, and the duration of how much the child has used atropine also doesn't really matter. Suddenly, after a use of a year or even 2 years, child does become allergic and then just does not tolerate reintroduction of atropine eye drops. The brand of atropine before 2017 November, there was nothing available as such as 0.01%. So we used to prepare low-dose atropine by diluting Moisol eye drops with the atropine injection as an ampule, or in one patient, patient number 3, we had diluted 1% atropine eye drops in water for injection. And in the 4th patient, who came recently, last Sunday, she had developed allergy to myopin eye drops, which was used since the time it was launched in India, 2017. The frequency of use was same in all the children. It was once at bedtime, but probably if you use it more frequently or higher concentration, we might have had more number of patients who would have developed allergy to this drug. And it's important for you to note that out of 4 children, 3 had previous history of ocular or systemic allergy. So a child having a history of ocular or systemic allergy, or who has had an allergy to 1% atropine eye drops in the past, is already at a higher risk of developing atropine to even this 100 times lower concentration of atropine eye drops. The most telltale symptom of the drug allergy is itching, and the most important sign that you should look for to find out whether child has developed ocular allergy or no is periocular redness. So in fact, you get periocular dermatitis as a manifestation of ocular allergy of atropine. Almost seldom you will see any follicular or papillary reaction if you reverse and look at the upper tarsal conjunctiva. This is our first child who developed severe allergy to 1%, which continued. He was referred to 2 skin specialists. Both of them said it is not because of atropine. So he continued to use 1% despite of being warned about the allergy. He then converted to 0.01%, and as you see over here, there is significant depigmentation that took place around both the eyes, only partially recovered after stopping atropine eye drops. All the symptoms promptly reversed when he stopped atropine eye drops. We did do a skin patch test to know whether there is any correlation of patch test with atropine allergy, and we found it does not correlate very well. In fact, we have done it in 3 other patients also, but they were on 1% atropine. Patient 2 had irritant kind of a contact dermatitis. This happens very quickly once you start the patient on 0.01% atropine eye drops. It may come even after first instillation of 0.01%. Usually it is due to the preservative used in the drug, not because of the atropine itself. It's because of an irritant in the drug formulation. Usually it is benzalkonium which causes it. Chlorbutanol is the second one, and the most common formulations now available and approved by our country FDA is stabilized hydrochloric chlorocomplex, which is less likely to produce irritant contact dermatitis. So this is less likely to be seen in future. You have third patient, as you see over here, who developed allergic contact dermatitis, quite asymmetric, more in the left eye than the right eye after around a month of use of the drug. And this is the child who in the past had developed atropine 1% allergy and was converted to 0.01%, and she came just last Sunday on myopin. She developed atropine allergy. So whenever you suspect a patient having an itching in the eye on atropine eye drops and periocular redness, must consider having an ocular allergy to atropine. Stop the drug at least in the worst eye and see after 3 days if there is an improvement. It confirms patient has atropine allergy. Stop the drug in both the eyes, let it resolve. You might like to use topical steroids. Avoid atropine again in these patients. Emphasize on other methods of slowing down the progression of myopia, which could be lifestyle modification or orthokeratology treatment. And last but not least, we have realized changes in the electroretinogram. Me and my fellow student over here, Neetu, we applied atropine eye drops in both of our eyes, 4 instillations in each eye. Other eye was controlled, and what we found was significant reduction in P50 amplitudes, which conveys that the macular functions are significantly affected when you use 0.01% 4 application at a time in one eye. The results were compared with other mydriatic agent like Tropicacil Plus, and at end of it, I think the pattern electroretinogram findings which we got in our study is indicating either an alteration in the signal transmission of the retina where cholinergic transmission is taking place, or more likely it is just the blurring induced due to cycloplasia and mydriasis, or both the factors are happening, and hence patients who are having pathological myopia or any reduction in the vision on low dose atropine, in fact you should not start them on low dose atropine, but if you have started, then you might need to do electroretinography, especially pattern ERG, to rule out the side effect. Now this is the slide which is not a part of the research, but just want to convey to you those who are using a low dose atropine. When you have started the patient on low dose atropine, when they come back to you and you do cover test with an accommodatory target for near, frequently at least 30% of your patients are going to develop esophoria. Yeah. And now we have 2 patients who had compensated monofixational esotropia following a surgery for intermittent exotropia, have decompensated, and they have been recompensated after we have stopped low dose atropine and introduced bifocals for them. So do look for fusion and ocular alignment in all your patients who have ESO with myopia. Generally it's an uncommon combination. You have hypermetropia with ESO, but if you have an ESO in a patient with myopia and you have started on low dose atropine, you may lose fusion on these patients. Thank you very much.